Hello and welcome to this EFNA session here in the TV studio. My name is Connie Lee and we are now going to talk about health literacy for patient and clinician communication. And for this talk, I cordially welcome with me Eva Galovic, Program and Engagement Manager at EFNA. Hi, welcome.
Hello, thank you for having me here.
Also, welcome Derek Reedman from the Community Advisory Board at EFNA. Hello.
Hi, thank you for inviting me.
And also cordially welcome to Jane Green, MBE, from the Community Advisory Board of EFNA. Hi, good to have you all here.
Thank you for having me.
So to get into this topic, to start right in, I would ask you to talk about challenges and changes to trial outcomes, please.
Well, there are numerous challenges when it comes to the clinical trials for neurological conditions, and this is especially when we think about how complex neurological conditions are, how unique they are, and that, of course, there are the rare neurological conditions also to keep in mind. But also with these challenges, there are opportunities as well. So one is the biggest issue that we have are the invisible issues of the neurological conditions. And EFNA did a survey on them last year, which you are welcome to read on our website. And this means that often the traditional standard clinical trials don't factor in these invisible issues of the neurological conditions. So often the trials have been designed maybe 50 years ago or 20 years ago. And it means that what is maybe the most important for the patients, for the improvement of quality of their lives, is not factored in. So now it's high time that we acknowledge this in a united way and begin to address the need for inclusion of patients' endpoints, not as a secondary endpoints, but as a primary one. What we know as a patient community is that very often trials that have been successful in managing symptoms and improving patient lives did not pass through because they maybe didn't fully complete the primary endpoints, fulfill them. However, this is exactly why we said that it is very important to include patient perspective, patient feedback, and have their endpoints as the primary ones. So an opportunity for the Brain Health Mission on education is also to bring clinicians and patients together so that we can identify which are those symptoms that are very important and have such an impact for the patient's lives, and that we can all work together. So this is actually a future for neurology.
Thank you.
I just mentioned a couple of challenges. So maybe the biggest issue that is indicated, but of course there are so many challenges in clinical trials, beginning with the health literacy.
Yes, and you also mentioned what I found interesting, that some of these trials are many decades old, 50 years old and older. Would you find it useful should something like expiration date be made, that after a certain amount of time trials have to be looked into, whether they have to be renewed, something like this?
Yes, that is definitely useful. And of course, just giving in all the new research that is coming and new technologies, they're constantly also need to be updated, right?
What are other suggestions you have to improve the problems, the challenges?
Well, there are numerous things that you can do to improve the challenges. I mean, these are really not easy tasks. They are big tasks and big asks, but with a lot of impact. So one for sure is improving health literacy of people, because people need to understand medical terms. Patients need to know what they're giving their consent for. This is also why they have, when they understand what the trial is exactly for, then they also have a higher buy-in in the trial. Then also they adhere more to the treatments. And I mean, we usually don't use the term of adhering to the treatments, because when it's used by clinicians, maybe sometimes it has this component of a blame that you're not doing something correctly. However, with health literacy, this can definitely be improved. Then there is one really important thing, which is education also of healthcare professionals regarding the communication, because they're extraordinary usually in the work that they do. However, this transmittance of the information, sometimes there is a gap between, how they communicate complex topics of neurological conditions to the patients. And we need to keep in mind that the patients come from all walks of life with different types of backgrounds, with, different types, even the language barriers are there, digital literacy. So there are a number of, let's say, challenges that then can be improved by addressing them with the, targeted healthcare literacy. So one thing that is also important to say is that inclusion is very important, because we very often have, marginalized groups of individuals that don't even get to the trial sometimes. So I mean, there is really, we could go on for ages around the topic.
To come back to one of your points, the health literacy, in which framework do you think should this health literacy, an education of this health literacy should happen in an ideal case? Because I think very often people feel left alone, that they have to educate themselves, have to Google a lot and find out by themselves. But is there another possibility you see in how to get yourself health literate?
Yes, that is a very good point. And to be honest, when you think that now at the current rate, 1 in 3 people will at some point in time be affected by a neurological condition. And I mean, this is now actually coming closer to 1 in 2. It is really a large number of population. So basically, health literacy, it should start from a very young age. So it should be talked about in public spaces, it should be talked about in school. When we, now coming back to the challenges, one of the very big challenges are stigma and, misunderstandings that the patients face. And it is really not easy, to feel all the stigma. In our survey, over 80% of people affected by neurological conditions felt some sort of a stigma or judgment by their surroundings. So it is a really important issue to tackle.
Thank you so much for this. I would now ask Derek Riedman to tell us a bit about ethical considerations for rare neurology.
So for the rare neurological disorders, I come from a Huntington's family. I'm gene negative myself, but I have many family members who are gene positive. And Huntington's affects about, 4 to 7 people per 100,000, but a research study in the UK actually puts that as high as 14.6 per 100,000. It can have a huge impact. There can be a lot of ethical considerations, especially around genetic testing. To give you an example, a family member of mine tested positive 3 years ago. This was the first time I'd ever heard about Huntington's, just 3 years ago. And we discovered at that time then, my father would have had the gene and he would have passed it down. So I'm one of 6 siblings. And between the 6 of us, we have 20 children. So when that diagnosis was made, it meant there was now 25 people who are at risk of Huntington's disease. There's an ethical need there to be able to support people after there has been a gene-positive result. And this happens quite frequently, especially with genetic testing. There has to be a lot more effort put into follow up with families and giving ethical consideration to the people, because when a family member gets a gene positive result, it's not just that family member, it's also the people around them that also have to have a lot of counselling, genetic testing themselves. So a lot of my family members got genetic testing. Some of them, in fact, many of them have come back as gene positive, and many of them gene negative. I myself, when I got tested and I came back with a gene negative, you would have thought that it would have been a great having a gene negative result, and it was. There was so much relief, but at the same time, there was a lot of sort of distress as well, because I have to think of all the family members of my own that are gene positive. After getting my own gene negative and with a lot of my family getting gene positive results, I took it upon myself then to actually start getting more involved in it. And there was one thing when I was at a Huntington's conference 2 years ago, somebody got up and talked about gene negative, and they talked about a thing called survivor guilt. So survivor guilt, it is very real, as I've experienced myself. And yeah, it's partially why I'm actually sitting here today. It's partially why I do the patient advocacy, but also my own interest in it. So since then, I joined the board of the Huntington's Disease Association of Ireland as a voluntary board member. I'm on the community advisory board for EFNA. I'm also a part of a number of public patient involvement panels as well. And when we talk about health literacy, it's very apt, because my own family member, they went 10 years before they get a diagnosis of Huntington's. This isn't unusual. There's a lot of misdiagnosis that goes on. There's miscommunication. And when we talk about health literacy, it's not just how a patient talks to a neurologist or their GP or their doctor. It's also the other way around as well, because the patient has to understand what their healthcare professional is talking about, as well as how they communicate that. So at the beginning of Huntington's, which is not unusual, you'll find patients say, there's something wrong with me. I don't know what it is. It's just something. I feel off balance. I don't feel right. And that's how it usually begins. And then it can go on for a long time. I mean, Huntington's being a rare neurological disease as well, not many people would come across it. You know, in Ireland, we have over 5 million people. There are approximately 700 people out of that 5 million that would have Huntington's. So a lot of, say, GPs, hospital things may not actually ever come across it. And certainly, I had never come across it until 3 years ago. And bearing in mind that I started my career as a nurse, and I actually worked in clinical trials. And then trying to get that awareness is very difficult. We can't all do the ice bucket challenge. Do you remember the ice bucket challenge?
Yes, I do.
Yeah, for ALS, we can't all do that. Mm-hmm. In Ireland, motor neuron disease got a lot of publicity not recently, because one of our state broadcaster reporters actually had motor neuron disease and made it very public and did a lot of fundraising, a lot of awareness for it. And those campaigns can make it a lot of public awareness, but otherwise it's very difficult to make public awareness. Even in Ireland, when the diagnosis was made of Huntington's disease in my family, the only resource that we had was the Huntington's Disease Association of Ireland. Dr. Google is a very bad doctor, but at least the Huntington's Disease Association of Ireland popped up at the very top, and we contacted them, and they were brilliant. They really were like a lifesaver in that respect. So there's a lot to be said. There's a lot of struggle with people with the understanding of Huntington's disease. As I said, my father was in a nursing home for 9 years with no diagnosis, yet he had Huntington's disease. And every person that has Huntington's may present completely differently. There's some people that will have much higher psychiatric issues, where some people, the priority for them is the movement issues. And once a diagnosis is made, usually because of movement issues, it can last between 10 and 25 years. And it's neurodegenerative, so the patient steadily declines. And I see this myself, steady decline. And this presents many ethical challenges as well, because over a period of time, a patient's voice has to be taken over by their caregiver, whereas the caregiver becomes the voice of the patient ultimately. And there are a lot of ethical needs to make sure that the voice of the patient is heard. As we've heard earlier, it's absolutely critical that the voice of the patient is heard. This is patient-reported outcomes. We have so much of this.
Mm-hmm. Thank you so much for these insights. One thing that especially got stuck with me is when you told us about how you found out about the term survivor's guilt, and how so very often when you just have a word for something, it already helps you understand what's happening, because you don't feel alone anymore. You know that it's a phenomena out there that people share with each other. So isn't it that also part of the health literacy to just sometimes have the right words, the right terms for things that you feel, which is a lot also about emotional support. That's I think also part of this journey and about these challenges, right?
Yeah, very much so. I mean, as I mentioned, some people, they come to the neurologist or they go to their GP first of all and say, "There's something wrong. I'm slightly off balance," and then they would get referred on to see a neurologist, and the neurologist, hopefully, if they have experienced the Huntington's before, and they will be able to make that diagnosis and send them for a genetic test. But in the healthcare system, it's not widely known, Huntington's, so people may not come across it very often. There are clinicians that may never see it in their whole career. I myself, when I went to my own GP and said, "Can I get a referral for a genetic test?" And he told me that he had only ever heard about Huntington's during medical school. Mm-hmm. And this is a GP who is older than myself, So that's how rare it can be. And there are a lot of sort of ethical considerations around making sure that clinicians are made aware of Huntington's and that they know what to do and how patients are actually referred on to neurologists and other support services as well. It's a very difficult one because in Huntington's disease, as happens with many other neurological diseases, such as Parkinson's and various other ones, people present with so many different symptoms and there's so many different things. And treatment is not necessarily the same for any two patients, And then with Huntington's as well, you can see that psychiatric issues, mental health issues, can occur long before you notice any physical motor symptoms. And this is not usual at all.
Talking about inherited conditions, such as Huntington's, and you talked about how actually the whole family would need some kind of support. What would you suggest, ideally, how could a support look like for the whole family, for the whole social system?
So ideally what would be nice, and what didn't happen in my own experience, is, as I said, when all of a sudden 25 people of the same family suddenly were at risk of Huntington's, there should have been, something in place where all of those would have been provided with counselling. They would have been given the opportunity to do genetic testing, because genetic testing comes with a lot of ethical dilemmas itself. Do you want to get tested? A lot of people don't want to get tested, especially given the age range. I mean, in my family, the age range was from the age of 20 right up to 50s, So some people don't want to get tested. And also giving people the opportunity, if they do want to get tested, they may not want to know the result. Mm-hmm. So, there's many different dilemmas, especially I notice with the younger people, they don't really want to get tested. The reason I got tested is because I have 5 children. And for me, it was very important that if they were going to, if they were going to have children, that they would know about the potential for this. And so it's very important, I think, very important that we give people that opportunity to either, to test or not. And there is, as I already mentioned, that ethical dilemma of, do I get tested? Do I not get tested? What are the consequences of getting tested? There are huge implications of getting a gene positive result, because it could be down to healthcare, it could be down to life insurance, taking out a mortgage. There's various implications that come down the line from getting a gene positive. And it's not just that, it's the psychological burden on the family, on those people that have to get tested, those people that get tested and are gene negative. In the case of one of my own sisters, she came back with a gene positive result, but there was no support in place for her own children who were now at risk. The focus was on my sister, quite rightly. She needed a lot of support and things, but there needs to be much more focus put onto the rest of the family, given that opportunity for them to get tested as well, if they so want, but also explain to them what services are available to them. At the moment in Ireland, there are no services whatsoever for Huntington's. So there are 2 Huntington specialist nurses that have been taken on in the last year, but that's it. And what happens there is, because there are no specialist services, it sort of propagates stigma with Huntington's, which is a big problem. And as you mentioned earlier, Eva, stigma can be a big problem. And again, we have to try and reduce that stigma. If we look at Ireland and we look at Scotland, in Scotland they have 10 regional centres that have specialists for specialist Huntington's, and they have the same population of Ireland. The Scottish Huntington's Association have spent years building this up. I've spent years. But their government fully supports it, and it gives it that visibility. And that's very, very important, the visibility in reducing the stigma that people feel.
It's an interesting comparison with 2 countries with the same population.
Right next door to each other. There's such a significant difference between the two. Yeah.
What, in your opinion, can an association such as EFNA do for the issues that you touched on for rare neurological diseases and the awareness and the health literacy?
So one of the reasons I ended up joining the Community Advisory Board in EFNA was actually around health literacy. We had a Stronger Connected workshop there earlier on in the year, and it was very interesting to talk about health literacy. And as I mentioned earlier, it's not just from a patient or a family member's or caregiver's point of view, it's also from the professional's point of view as well. So health literacy cannot be underestimated at all. It is so important, and it was an extremely good workshop that we had earlier on in the year.
Thank you. And I just wanted to add regarding the workshop. So basically, it was very interesting that because we needed to self-evaluate our own health literacy, and it was only around, on a scale of 10, around 7. And this room was packed, with people who are patients or have a medical background, some kind of medical background. So people who actually you would expect to be very health literate. So now we come back to this point of inclusion and discrimination where maybe, a lot of people don't even have access to this knowledge that all of us who are in the room have. So you can imagine how much improvement their health literacy needs as well.
Definitely.
So an organisation like EFNA, and one of my reasons as well being part of this organisation is because it takes you outside the country level, your national level, and it gives you that platform at a European level. We are able to look at how policy is done at a European level and influence those policies, very much so. It's important to look outside of just your local area, your national area, and to look at it from a European levels. I mean, there's MEP special interest group as well. So we want to be able to influence policy at a European level, which then propagates down to the country level. And again, that visibility that we can bring across Europe. There's a large amount of people in Europe with rare neurological diseases, and I do understand that it's difficult for every single rare neurological disease to be given that public awareness. It's a challenge. It is very much a challenge, but there is an ethical need there to make sure there is public awareness and make sure that there are specialized supports in place for people with Huntington's.
Mm. And also, since you mentioned the Ice Bucket Challenge, it's something in the past, but we still remember it, and it raised a lot of awareness. So I think sometimes maybe the mistake is in thinking we have to do all the campaigns at once for everything, and of course we cannot do this. But if we give each issue, each topic 1 or 2 years of spotlight, that might help so much, because it also gets stuck in people's memories.
But if you think about the Ice Bucket Challenge, how many people today actually remember what it was for?
Well, that's a good question. I'm not so
Because I know, like we were all throwing buckets of ice over our families and everything, but sometimes it gets lost in the excitement. This spread like wildfire.
But I think if 1 of 10 people remember what it was for, then it's already worth the cause.
Yeah,
so.
it is. Yeah.
Yeah. Thank you for these insights very much. And I would now ask Jane Green to talk about ethical equity for all.
Thank you. Hello, I'm Jane Green, MBE, and I am the chair of SEDSConnective and EFNA Community Advisory Board member for 2025. On the right-hand side of the slides, you can see my qualifications, which I'm really proud of, and I'll tell you why in a minute. But it includes a few degrees and a former assistant head teacher. So the question is, what is hypermobility and neurodivergence? And what I'm going to talk about might be, completely novel to some of you, and to others, of course. But we've only got the data relatively recently in research, probably about 11 years. So hypermobility, there are lots of different acronyms like Ehlers-Danlos syndrome, hypermobility spectrum disorder, pediatric joint hypermobility. There are a lot, and associated conditions. But it's about the connective tissue in the body, and we have connective tissue throughout our body. But with us, something called collagen is weaker, is much stretchier than the general population. And it affects all systems in the body, so brain and body, and that's the invisible bit. So, and it's not been believed historically. And so in these neurodivergence, particularly because that's where the data is, but probably more, which you'll see, autism, ADHD, dyspraxia, and Tourette's are the main key ones there, but we probably know there's more. And I'm very lucky to be alive. So Ehlers-Danlos syndromes have 12 types, which can be very, very rare. But we think the most common types, hypermobility, Ehlers-Danlos, there are loads and loads of acronyms. It's like alphabet soup. But we think they're really common, but just very rarely diagnosed. And so these are some of the common ones we have. Our charity has 15,000 members, and we all flare, like you just said, Derek, we all flare in different ways, but these are the most common ones. I left school at 16 with just 2 basic qualifications, and I was bottom-setted in class. When in high school or secondary school, I was considered dim, stupid, and a hypochondriac. And when I wasn't ill or injured, I was often missing in school because I couldn't see the point. I was also a selective mute. And so I spent quite a few decades thinking I was dim. I knew I was different, but in those days, because I'm quite old, we didn't have the science then. And the only autistic people around were people in the Rain Man and so on. Later on, I got married, I had children. My eldest was very ill from birth and multiply neurodivergent diagnosed before the age of 3, autism, ADHD, dyspraxia, later on dyslexia, and also had a learning disability, but a lot of health issues. And my youngest child also had significant health issues like eczema and severe allergies, which continue and is a very key indicator, like eczema, for example, rhinitis, and then anaphylaxis. And so I became a single parent, and I wanted to help others because I didn't have social media. I didn't know anyone. I was completely isolated. And so, but I knew there'd be other people like us because I was called a refrigerator mother in those terms, like a bad mother, like stigma, all that. And I was just used to it. It's just carried on. And so I was always being asked to go into nursery school to help out. So I helped them. And then I thought, well, I should be paid for this. And I didn't get any support. So I did that. And then I thought, well, I think I could do a better job, ego, than an educational psychologist. So I wanted to study psychology. So I did that with a pile of books, really. And then I won awards and I became a teacher and did more degrees and more awards. But throughout this time, I was not believed myself to have hypermobility or any, in that time, autism. I knew I was, but women were not allowed. These are some of the common symptoms we have, and pain is key. But what happens is it's often misattributed to other things, particularly if you're neurodivergent. So things like fidgeting, or if you're ADHD, might be fidgeting, but it also might be because we're trying to relieve pain because of the hypermobility, because we get very, very stiff. And it sounds like hypermobility, yes, we can bend, but we actually have a lot of pain with stiffness. I did get other diagnoses like fibromyalgia, irritable bowel syndrome, chronic fatigue syndrome, but they didn't really help what I'd seen in all the schools I'd been to. I'd seen the pattern and with my children. And this is very key because some of these issues we have, like sprains, dislocations and bruises, can occur with no preceding trauma. So it's disbelieved. And that's what happened to me and my children as well. And of course, if you're in pain and you're not believed, then it invalidates your self-worth as children. You grow up with trauma. This is some of the research. So long COVID also, very familiar symptoms to us. And this research shows that if you have differences in your connective tissue, like us, hypermobility, you're 30% less likely to recover, have more fatigue and pain. And this one, so in 2016, a large Swedish population study found that if you have Ehlers-Danlos syndrome, you're 74% more likely to be autistic and 56% to be ADHD, and also the siblings. And this one was about if you're neurodivergent, and those 4 I mentioned at the beginning, you are over double more likely to be, if you've got connective tissue differences, you're more than double likely to be neurodivergent, have dizziness, pain, and fatigue. So, and this is the gastro graphic, which shows fear of food. I was so ill, I had to retire in 2015. So I had a short career of only 10 years, despite getting to assistant head teacher. And I was so ill, I got my hypermobility diagnosis. I was bedbound for 2 years. I had no belief because you're discharged immediately after diagnosis. Only then I started social media, and I knew what I'd seen as a pattern was out there, and I wanted to help, but there was nothing out there. And I couldn't eat. I couldn't eat at all for 3 months, and I was an adult person. And so I was disbelieved because all tests come back negative. And so I was in so much pain. I wanted to eat. I've got children. I wanted a career, and I lost all that. And then I nearly lost my life. In fact, my children asked me if I was dying, and I didn't know what to say at that point. I couldn't breathe or anything. And that can be part of it. But I did get a fear of food because it hurts so much, and there's a lot more on that. So, what I say, a quote is, I don't think the bendiness in my brain, I now have quite a few neurodivergent diagnoses, ADHD, autism, probably more hypermobility and so on, probably dyslexic and dyspraxic. But I don't believe my brain is a weakness in that way. I believe it's a strength, but I do believe we should have support in our body because there's a weakness there and we need belief. And we think, you know, there are even more issues. So this science, this neuroscience is still growing. Our patron is leading this as well. And I'm really proud because I've managed to start SEDSConnective in 2018 with just 2 people in a village from nothing. We're now a global charity and the first to connect neurodivergence and hypermobility because there was nothing out there before. So I've got some peer-reviewed papers there. And I'm very lucky to be honoured with an MBE, which in the UK is significant and hopefully will help many others do more. Those are my bendy knees. I don't have many photographs back then. But, you know, talking about diagnosis, it took me till the age of 53 to get my first one and my ADHD at 61. So, you know, I'm not the only one. We have thousands of members with this story and it's heritable. So we have to join up much, much wider and think out of silos. So thank you for that.
Thank you so much for sharing this impressive story. So many things coming up with this. For one point, you said when you were younger, you just felt as if you were different. I think that's also something that many children, young people in many regions of the world are familiar with because they feel they are different, they are being told they are different, but I think that also probably keeps them from finding support and finding a diagnosis because it just makes them accept a state, all right?
Well, in the UK, there's much more awareness of neurodivergence, autism and ADHD, so they do. There's a big waiting list for diagnosis. I mean, it can be 5 to 7 years because it's really, but that's because it wasn't diagnosed before. So we've got a huge wave. But they do get support, or should do. But what they don't understand is the physical health impacts the brain. It really does. So anxiety can be physiological as well as mental and emotional. And that's due to something called a static intolerance or postural tachycardia. It's a dual thing. And also emotional dysregulation can be due to our connective tissue differences, which no one thinks of, but makes so much sense. So if you don't join the brain and body up, it doesn't make sense.
How do you see the connection of having to deal with neurology and psychiatry as it is for ADHD? How is this process? Does it have more advantages or disadvantages in your opinion?
We are about connection. I absolutely always wanted this and I'm really delighted it's happening more. We've just had an ADHD report for the government. It's not there yet, but connecting, say, for education to health, which is absolutely key. So yes, if you, as I said, trauma exists. If you're not believed, you're invalidated when you're young. And ethically, we need to look at this much, much more and join up because we are joined up, I think. And I know it affected me as an adult. I find it difficult to understand when I was young, but I think I see it now with the younger children not being believed or being told it's all in the environment or the head or the social things or your emotions. But, and it's historical, so they lose social mobility, they lose their employment. The same story, basically, as me.
I wonder, you made these experiences of, as you just said again, losing self-confidence and self-value because you weren't believed by doctors, by physicians. And then you also told us that your children had certain health issues. Was it for you as a mother easier to go through this process with and for your children, or was it even harder because you already had these bad experiences in the past?
Gosh, well, I think both actually. Obviously, I had a passion to help my children. No one else believed them, and I was told various things which I would not do, and I didn't do, and I'm very proud of that. But I was doing something that wasn't there. I was creating things, and I still am. But it's it's really key. I think all parents would do this, you know, surely. Well, hopefully all, because we have to for future generations. You know, we're right at the cusp of this. This is life-changing, I think, transforming health for neurodivergent people. Because historically, you were talking about research. It's always been male-biased. I'm sorry, it's been male-biased research on neurodivergence. And our symptoms are very affected by hormones. So we do have boys and men affected, and they can be quite severe, but mainly it's girls and women, and that's because of our hormones. So you're most affected between 13 and 50 in different stages, particularly, and it's really significant. So you can be hypermobile and male and not have any symptoms, and that's lovely. But most of us have a lot, but they're invisible, they're not understood. Doctors aren't trained in this at all. The secondary stage rheumatologists can't cope with this anymore, actually. So, you know, we're trying to do a lot as SEDSConnective. You know, we talked about Google. We actually started this, and then Google's followed us. It's true. If you look, our name will come up. So we started this, and it's not just me, it's all the volunteers with us, voluntary doing this.
It's interesting because even though Huntington's and a lot of neurological diseases are so different, there's an ethical consideration has to be given to listening to the voice of the patient. And it's not just the voice of the patient, it's the voice of the carer. And in your case, you know, the mother, you know, the voice has to be, they have to listen to it. Those are serious ethical considerations. And patient-reported outcomes, you know, very important, because with rare neurological diseases, there's not a lot of clinical data there. There's not a lot of clinical trials, in fact. And even when they do have them, there's so few patients, so few people that can be in there. And although, you know, like a drug will help with motor function or something like this, you know, unless you hear from the patient themselves how that impacts them, it's not necessarily what the drug is doing to them. It's their overall, how it makes them feel overall. But
yes, so just to build on that, it is really important, as Derek said, that we listen to the patients, because, for example, for older communities, it is very important to have a voice and to speak, to be included in the community. But maybe sometimes clinical trials, they include some different measures like a movement, and they're not including what is actually the most important for the group of patients. Like there was this one reported case when, you know, in the trial, the measure was how fast a person goes through a maze, and, you know, regarding the speed. And for the kid who actually said it afterwards, it was not important if he would be 2 or 3 seconds faster. For him, it was important that he could get out of the vehicle, so either a car or a bus by himself, so that he doesn't need assistance, and that you know, other children are not staring at him. So this is why it is so important to think of what is the most beneficial for patients, and, you know, like what impacts their quality of life.
The practical use. How do you think, speaking of also the problems of belief in patients by physicians, how can this be improved, you think?
I think the community voice needs to be listened to ethically. I mean, not just because of SEDSConnective leading this, but all our followers in different communities, because we're extremely wide, as you've just seen. How can they improve it? I think we need the join up, as I said. We need to work together to do new research so we could co-productively lead it. And I think co-production is really key, as much as you can in medical, but have some power so you know where it's going, you know, because you can do, it might sound really good, but where's it going to be used? Is it going to have value to our generations going forward? And the funders, of course, it's really key to understand that what they might have learned in the past about something can sit in silos. So you need to open your mind. So I would say what you need to do is open your mind in the nicest way and really listen to the new data and our voices, and we have a lot of expertise in different ways, and how it affects everything, education, maternity. I'm doing things on birth and because there's so many issues. And the earlier, the better. So I'm going to go back to that as well. Earlier, the better. It's very hard to diagnose before the age of 5 hypermobility, but you can put supports in. And as I said, neurodivergence, or autism, ADHD, particularly dyspraxia, and pre and post support diagnosis. There was nothing, there's been nothing for us at all, really, apart from us, and we're trying to do more. But there are silos of different groups and charities doing different things, but not joining them up. So that could all be much improved, and joining up with other, you know, communities and charities, because we've got links, and some of the other presentations there under that umbrella are there too.
So I wanted to ask also, connecting to that, what role has EFNA played for you in your story?
Oh gosh, I was so delighted to join, actually, because we're in the UK and registered there, but we have a lot of members in Europe, so we know that. And we know that neurologically, I get asked questions from clinicians in my country and Wales, actually ringing me up, and they say, now, they just ring me up and they say, now look, where does hypermobility sit? Does it sit in the heart, you know, cardiology? Does it sit in the gastro? Is it in neurology? Where does it sit? And well, I'm not a clinician. I don't know. I think it's throughout the body. So, sorry, EFNA, I think what we're doing now is really important. We're training, you know, we're helping train health and doctors as well. And we do have doctors in our group, as I said, and psychiatrists, so that's really good. But so that's a health literacy, but also health equity or inequity we've had for so many decades. Hypermobility, in a way, was first mentioned 400 BC by Hippocrates. It's time we moved on. I'm just saying.
Thank you so much. So health literacy, all in all, if we sum it up, is so much also a process of translation. And so basically it's a communication process. So it's always important for people to come together. So always also like in congresses like this.
Yeah.
So how can a congress like we are here at just right now, question to all of you, help all of these causes in all their ways?
So if with Huntington's, we do have the Huntington's, European Huntington's Association, who have a congress every second year, and it brings patients, caregivers, clinicians all together, and that community that you have at a European level, you get to meet people from different countries, and it gives you perspective, because sometimes you think, oh my God, it's terrible in my country, and then you see, you know, it's the same in many other countries, and there are extremes. Scotland, a model that we all want to aspire to, versus Ireland, who have virtually nothing, and everyone in between. So, you know, Europe is a community as well, just as much as we have a local community. The Huntington's Association of Ireland is just a smaller version of that community.
Yes, and it's exchanging ideas, also giving support, learning from each other, and creating new ideas. So it's very important to have congresses like these.
And then we see Jane, who has started from the very bottom with nothing and is have to build that up.
And we're in the UK, but as I said, we've got lots of European members, and we get clinicians asking for help for their members. So hopefully, connect. We'll see what we can do, and hopefully, EFNA, you know, will build this. What is needed? Equity. We do need this for everybody. So get in touch.
Beautiful last words for this TV session. Thank you all so very much for taking part in this. This was our EFNA session here now in the EAN TV studio. Thank you so much for watching. And we will continue at 3:30 in a TV session looking through the lens of diversity, equity and inclusion. So we will kind of stick with the topic, addressing disparities and gender-specific challenges in neurology. Hope to see you again later.